I just really wanted to give you some background about the work that we've done here in Cambridge, and also to talk about some of the benefits and the lessons learned. Just by a little bit of way of declaration of interest, so I've done some work for HIMSS, both at a UK and at a European level. And the first thing that I really want to say is a big thank you to Keith McNeill, who I'm sure you will all know far better than I more recently. Keith obviously was our chief executive at Cambridge, and this is a quote from our government secretary of state in 2017, not long before Keith was due to return from us to yourselves. And the reason that I want to put this up is certainly at a personal level, but I think at a institutional level, we are all eternally grateful to the work that Keith did with us at Addenbrooke's, and the core of what you want to be able to do and the core of how you deliver that really does depend on that vision that comes from the most senior leaders in your institution. So this is a picture of our campus. I'm not sure if you can see my cursor, but all of the less glamorous buildings at the lower end of the picture are the NHS part. The much more shiny buildings and the newer buildings towards the top of the picture are the university, the global headquarters of AstraZeneca, and some other buildings. But nevertheless, the campus is growing. And in fact, this was the driver for the work that we did right at the very beginning, when this work started in 2010, when it became apparent to us that at that point, as the campus was going to grow, for a hospital of our aspiration to continue with a paper-based system was going to be fully inadequate for the care of our patients and the work that we wanted to do going forward. We do historically, for legacy reasons, have two hospitals, Addenbrooke's and the Rosie. The Rosie is the maternity hospitals, but in fact we behave as one fully integrated system, and the Women's and Children's department is just one of our 5 clinical divisions. So a little bit about us, 1,200 beds, our local population just over 500,000, but we serve a regional population of between 4 and 5 million people. And we also have some national services that we provide for very specialist cohorts of patients. And the numbers are on the screen, but between 120 and 130,000 people in the ED day cases, 70,000 inpatients and so on. We have around 11,000 NHS government employed staff, but when you add on university employees and visiting people, that number increases closer to sort of 13 to 14,000. And one of the challenges in the implementation of any sort of digital record, which I'll come on to, is at a very basic level, do you know who your staff are and do you know what your staff do? And at a very simple level, is everybody who's called a secretary doing the same sort of thing? And if they're not, and you don't understand that, then that was going to cause you quite a lot of challenge when you give them all the same sort of security in a digital system. And on the day you switch it on, you suddenly find out that a whole load of people can't do what they were supposed to be doing. And a whole load of people can now do a lot more than they were supposed to be doing. And it can be a real challenge. And the same thing applies for all professional groups and grades. So we started back in 2010. Our chairman at the time sent an immortal email, one line, which is, what would it take to implement an electronic patient record? And the challenge for us was that we had very few systems that were worth keeping. Many of them were decades old. Our lab system, our patient administration system were 18, 19 years old with no, really just the most limited functionality, no significant support, no audit trail, and nothing that was very modern. We started our procurement processes through 2011, went through all of the EU rule processes at that time and got to a preferred bidder status for both software and hardware back in 2011. But it took us another year to go through all of the assurance processes with government regulators and others before we were able to sign any contracts. And we had split our work into the software implementation, for which we chose Epic, and then the changes to all of our infrastructure, for which we chose Hewlett-Packard. And this diagram will be something that you guys will be familiar with as you go forward over the next year or so, where we started from the point of signing all of the work around training our team in order to configure Epic to work for us and doing the clinical validation pathways, configuring the system, testing the system. And then for us, towards the end of 2014, we trained all of the end users. We trained 12,000 people in 9 weeks, initially training 6 days a week, but by the end of the time we were training 7 days a week from 6 o'clock in the morning till 10 o'clock at night. And we went live on the morning of the 26th of October. Those of you who are lovers of history, that's the anniversary of the gunfight at the OK Corral. And on occasions it did feel a little bit like that. But for us as an institution, this was the entire hospital, everybody all in one go in the usual epic fashion of that big bang deployment. And so on the first day at Go Live, in essence, every single epic module that was available to us in the UK was what we implemented across the entire estate, as I've described. And then over time in 2016 and 2017, perhaps a little bit later than we would have liked, we implemented initially the Mychart patient portal and then the welcome check-in kiosks. In 2018, we implemented linking with other hospitals through Care Everywhere and the primary care portal EpiCare link. And then in 2020, at the very early part of the COVID pandemic, we implemented a connection to a UK national system, something called GP Connect, which allows us to see primary care records from our instance of Epic. And so where have we got to? Well, so we have a single record. Pretty much everything we do is done in Epic, where Epic isn't the prime system because we've needed to keep it for legacy reasons related to, say, some bespoke or regulatory activity like blood transfusion or nuclear medicine or radiotherapy. Then those systems are interfaced into Epic. So we have about 120 systems connecting to it. But the pivotal thing is one view of the patient for everybody to see brings us massive safety benefits. We moved from having just over 5,500 PCs to just over 8,000. We've deployed a whole series of handheld devices. And obviously with the COVID pandemic last year, although we had always had remote access, which was typically used by between 500 to 1,000 people a day, with the pandemic, we're now seeing off-site access to the system somewhere in excess of 2,500 concurrent users per day. And at the peak of the day, peak of activity, we have about 3,500 concurrent users. All of our critical care beds, ventilators, physiological monitors, our theatres are connected into Epic. And when I first wrote this slide, we had 148 critical care beds. Again, with the pandemic, that number has now increased to over 220, and they're all integrated. And the benefit of device integration is profound. It saves a lot of time for our nurses and really turns them back from being people transcribing information, on occasions making errors, but really turns them back towards patient-facing activities. And we've seen real quality improvements in the care that we've been able to deliver. And then finally, with our Biomedical Research Centre, we've done work on setting up a mobile apps factory framework, and that's allowed us to create patient-facing apps for a number of clinical circumstances as well as clinical trials. And in terms of benefits, well, I could talk for hours and hours, and we'd be very happy to share with you a whole raft of benefits that we've described, if that's helpful to you. Electronic prescribing brings a whole raft of benefits. We've seen a complete abolition of safety-related issues in the paediatric intensive care unit. General decision support related to prescribing based around allergies saves us at least, I think now probably more than the 850, probably approaching 1,000 significant adverse drug reactions a year. And that for us, we believe, is somewhere in the region of 2,500 to 3,000 bed days a year. One of the challenges around how do you quantify these benefits is the value that you attribute to them. At a clinical level, it's really obvious to see that avoiding all these significant adverse drug reactions is of benefit. Some of my colleagues in finance say, well, that's fine, but you haven't saved me any nurses or any beds, and you haven't shut any space, and you haven't reduced any costs. But you know, my argument is, well, we're able to do more with the same resource that we have. And that does need a little bit of refactoring in terms of your institution sometimes, certainly for us in a socially care-funded healthcare system, as to what is the aim of what we're trying to do over and above, obviously, improving the quality of care. strict cash release and financial benefits can be sometimes quite challenging to find. But we have integration to our dispensing robot, which has allowed us to discharge people. Critical care have a rapid response team, so we now have circumstances where nurses are filling in observations on handheld devices that generates automated warnings in the system, automatically routing messages to the rapid response team, and they're getting out to see patients much, much more quickly. And prior to the COVID pandemic, what we were seeing were the physiological Apache scores of people being admitted to our intensive care beginning to fall, suggesting that we were actually getting to these people earlier and intervening earlier with better outcomes. And that's been very positive. And then where you start to get into the more complex things are related to avoidable ventilator-related deaths. So there are well-described international algorithms on how to ventilate people well. It's a complex calculation. It's a difficult thing for anaesthetists to do on the fly, but the system does it for them now reliably, several times a day, automatically. And just by their own review of that information and minor tweaks to ventilation, they're seeing benefits. And then for our hospital, a whole raft of benefits, and I won't go through all of the fine detail here, but we shut all of our medical records. We used to pull 45,000 sets of notes a month. That's now gone. Our clinical coding and our depth of what we call depth of diagnostic data, understanding about patients with better quality, ongoing, consistent clinical documentation, the prime aim of which is to drive good clinical care, but the subsequent consequence of which is that we're better able to bill for the complexity of care that we deliver for our patients, has led to a massive return on investment. Again, some challenges in the UK about how that money is actually refunded to us. Over 5 years, we should have had £87 million of additional income from our commissioning agents. Unfortunately, their health budgets are somewhat stretched, and so they haven't always been able to pay that. But it again is a challenging conversation sometimes when you look at the business case around these sorts of things. In essence, this clinical coding benefit in itself should have paid for what we were doing in its entirety, but because of structural challenges, that's not been possible. But I think probably more importantly are things like where there are direct funding streams, for example, for us, biological medication and special cost drugs, we are able to close the gaps in the amount of money that we were losing before due to inadequate billing purposes. And even more important, obviously, with COVID is the real-time bed occupancy status that we see that helps us not only manage our own internal work within the hospital, but as a regional centre has been really pivotal in helping us make sure that we can deliver better care for our patients. And a couple of slides really just to talk about the capability. I think one of the real benefits of having Epic and the teams that you will have and the capability that you will have is that you will be able to make changes to your system as and when they suit you. You will be able to interpret your own local health needs based on socioeconomic factors and any other local factors to decide what you do and when you do it. So this is an example of an accelerated change process during COVID. We run our hospital with a gold, silver and bronze major incident command, and our infectious disease team last March said we want a new order set in the system to reflect the needs of the acute teams looking after COVID patients, and they submitted it on the Wednesday, and by the Friday afternoon it was built, tested, and in the system and live and deployed to every clinician. So it didn't matter which clinician you were. As soon as you saw a patient with COVID, the system was prompting you with, this is the best practice. This is what you should be doing to look after these patients and investigate them. And you have absolute consistency across every team within a few hours, and it makes a huge difference. We've been able to take real-time data out of our Epic system and feed that into an algorithm learning system that now is predicting for us what our forecasted activity in our ED is. And again, I know this sounds in some respects very basic, but it means that we can much more easily predict what's coming through our ED. We've changed our staffing patterns to reflect that, so that rather than have staff rostered in a very regularized way, we're doing our best to match activity versus resource. And for COVID work, here's an example of a COVID tracker. This is in ClickView, which is what we use for our business intelligence, and this takes real-time data updated several times a day, showing our infectious disease teams which patients have got COVID, all the details of all the swabs. They can drill down to a patient level and so on. And in fact, because we're one of the very few hospitals in the UK that can deliver this sort of data, so much of what we've been doing has been feeding the national governmental scientific advisory groups as to what is happening with COVID in the UK. But other things, as I mentioned earlier, is about how do we do more with healthcare for our patients. And so we've really worked on joining up healthcare. So EPIC obviously sits at the heart of that. And there are tools such as Mychart and Care Everywhere and Epic Care Link and GP Connect, which I referred to earlier. But how have we use those? Well, Mychart itself has been pivotal. Over a period of 2 years, from December 2018 to December 2020, we've signed up over 80,000 patients. Our haematologists and many teams are now reporting that with the use of Mychart, they're able to significantly reduce the number of people attending the clinics, whereas a haematology clinic used to be consistently overbooked by 10 to 15 patients per clinic. It's now barely overbooked at all, and if so, by 1 or 2 patients, and yet the correspondence with the patients and the care with the patients is still successfully delivered. We put patients on our Mychart design authority. The patients drive and tell us what's the functionality that they want next, what are the things that are going to be most useful for them. And when we moved a year or so back to automatic results release, whereby the patients get their results at the same time as the clinicians, the patients were pivotal in that. For us, for reasons that still aren't terribly clear to me, the clinicians who saw the fewest number of patients were the most reticent about releasing results to the patients. The patients said, these are our results, just give them to us. How can you hiding results from us help us in any possible way? We release best part of 140,000 results automatically every month. We have not seen any increases in unnecessary, if you like, messaging between clinicians and patients, and our patients are much better informed and much happier as a consequence. And certainly with COVID, this has proven to be immensely valuable. And then we implemented a whole series of safety aspects. Back in 2018, we started a process of saying, well, we want to use barcoding technology to make our hospitals safer. And this was very much driven by a desire to be a better hospital. We implemented barcoding medication administration, transfusion sample collection, breast milk technology from start to finish in a closed loop situation. In the UK at that time, it was said that barcode medication administration, A, wasn't possible, and B, wasn't valuable. And certainly we had some reticence from some of our staff. Our senior nurses were saying, well, we're not seeing these problems. And then one day, as we were implementing it, a nurse gave an infusion to a patient. And for whatever reason, she chose to scan the patient and the drug after she'd given the infusion, at which point the system came up and said, well, I'm really sorry, but you've now given the drug to the wrong patient. And that sort of was a little bit of a turning point, with people beginning to realize that these things were important. And so here we have some tools that our senior nurses are able to see every day. They're able to tell us when there are alerts in the system, stopping the nurses from making errors. At the moment with COVID, we are redeploying our staff to the tune of around 50,000 hours per month of taking staff from their normal working environments and putting them somewhere else. And that is putting them in an unfamiliar and in a stressed circumstance. And what we see day to day on a background of around 11,000 administrations a day is that nurses are, the system is stopping nurses from making drug errors between 7 and 20 times per day, every day. And we, again, believe that that is saving us many, many thousands of lost bed days per year from adverse drug reactions. And our nurses absolutely love the system. And what they're saying is, it doesn't stop me from being a nurse. It doesn't stop me from being a professional, regulated individual and doing the best I can. But it does give me confidence that the system is going to support me to do the right thing for my patient. We built digital support tools based on sepsis. It will be, many of you will be familiar with this. But basically, through very strong digital engagement and very strong engagement with our acute medicine and our emergency care team, we built tools in the system that tell the doctors and the nurses when the patient arrives. There are constellations of clinical parameters in the system that help the patient, that would lead you to believe this patient has sepsis. And you can see the outcomes here of increases in antibiotics being administered within 1 hour. We know that for every hour of delay, there's a 7 to 8% increase in mortality. So this is having real benefit. And certainly for us, the calculations from 2018 and 19 suggest that we have at least 64 lives saved. And that's ongoing and has now become part of the standard fabric of our building and our institution. And again, when we talk about value from healthcare, these are some of the tweets from some of our patients about how well they're doing as a consequence of the work that we did around sepsis. And we, again, find it challenging to find cash releasing benefits, but we can describe quality, safety, timeliness, effectiveness, equity, patient-centered benefits that can be described at length. So back in 2014, just before we went live, we were a HIMSS Stage 1 hospital. For those of you not familiar, this is their inpatient EMR adoption model that describes how well you use digital tools to support your system. It's a measure of system adoption, not a measure of what you've turned on. So you need to be sure that your clinicians are aware and are using this. And we went from stage 1 to stage 6 just within a year of go live by 2015. By 2018, HIMSS had made the criteria even more difficult, and so we revalidated at stage 6. And then last year, we were very pleased to become the first UK hospital for inpatient care to validate at stage 7, and only the 7th hospital in Europe. And I think really, again, the important thing here is that this is a measure of how well your staff are using the system. And it's the staff really that I just want to finish on as I talk for a few minutes more. None of the work that you do is going to make any effect or be valuable if your staff aren't engaged with what you do and you can't bring them along with you. And this is an annual survey that we've run for the last few years. We didn't quite manage to do it last year with COVID, but we're picking it up again this year. And you can see over time how things have changed as we've gone through the delivery of our journey. And not everything has been perfect. When we first started, you can see that the score for the support that was available was a negative net promoter score. And whilst it's improved over the years to plus 39, I'd still like it to be better. We had problems in 2019 with log-on times, and we've changed our infrastructure provider, and that has improved substantially. But the reality is that all of the benefits that I've talked about, all of the tools that I've talked about, all of the things that we could talk about are only deliverable because of the engagement from your staff. So when I think about the lessons that you might take away from this, first of all, digital is not a bolt-on. Doing this reflects an underpinning change in mindset. And this was one of the challenges that I don't think that our NHS recognized back in 2014 when we first did this. And although at the point that Keith was leaving and to return to yourselves in 2017, the NHS was very happy to say what a great job he and we and others had done. The time between 2014 and 2017 had been very difficult for us, and we got a lot of adverse publicity for doing that. And I would still do the same thing again. I believe it was absolutely the right thing, but I think our NHS has become a much more educated NHS over the time. And you will obviously be able to learn and benefit from work that others have done before you in Australia. It's absolutely imperative that you understand your staff and their roles, and you need to be able to describe what I call the who, what, the when, and the why. All of those things are clinical, administrative, and operational, sometimes professionally regulated, local, national guidance, whatever it is. All of those things are things that you need to be able to describe, because EPIC typically becomes the how. And we still on occasions will see change requests from staff saying, I would like to do X in the system, imagining that just because you build X in the system, that will somehow magically make everybody do what it is that they're supposed to do. And it doesn't. We had a request from the hand physiotherapist saying, it'd be really great if the plastic surgeons would fill in this 15 screen referral form, because it would make our life really easier. The response from the plastic surgeons was substantially shorter than 15 pages in length. And as you might imagine, and nobody had bothered to talk to them or understand that. And so if clinical teams can't agree on those operational workflows, then the technology is not going to fix that. For staff engagement, going live, change management, make it real. Too much engagement is not enough. The things that we found to be very, very beneficial were dress rehearsals, looking at operational readiness. And by that, I mean, for every clinical and operational person in every clinical and operational area, do they know what they're supposed to be doing? Have they got the equipment that they need to do it? And does the equipment fit in that space? So we had our executives pretending to be patients. Our COO, she pretended to be a lady having twins. She came into the ED, was wheeled to the maternity hospital, went into the theatre. One baby went to the NICU, one baby went to the ward. And in the midst of all of that, it was only then we realised that there wasn't now enough physical space in the theatre for the resuscitation equipment, the computers, the operating tables, and so on. And so the more that you can practice those dress rehearsals, the better. And in terms of making it real, I think it's really important that staff understand that there isn't an abstract separation between your hospital and your community. Your hospital and your community are the same. At any time, a staff member or their family member or whoever might be a patient. We've seen that obviously with COVID, but even before that, my son was born in the Rosie Hospital. When I fractured my wrist many years ago, it was fixed at Addenbrooke's. My wife has been seen at Addenbrooke's. The notion that the staff and the patients are different is not real. And everybody needs to recognize that the pursuit of ever increasing high quality care is a benefit for all of us as a community. And this is not just about changing your institution in an abstract way. So the last thing really, just to reiterate what I said about defining value and measuring benefits, think about how and what you want to do in terms of that. So for us, as I say, cash releasing benefits are hard, but quality, safety, efficiency are very much stronger. There are a few more slides in there which I've left just for reference really, which is looking about the things that we want to do going forward. But I'm going to stop there. As I say, I could talk for hours. We've got lots and lots of material that we're very happy to share with you. I hope that that's been helpful. Thank you.